decline. So we are prophylaxing all Down syndrome infants with without comorbidities for 2 seasons. What about cystic fibrosis? With the use of palivizumab, there is a decline of almost 86% in RSV hospitalization. But we're prophylaxing only the CF patients in the first season. In the second season, if they have failure to thrive, deteriorating lung function, or have numerous admissions for recurrent infection. So the target for the second group is for the severe CF patients. With severe immunocompromise, you can see the RSVH hospitalization rates drop after palivizumab. And of course, who do we prophylax? Majority, the primary immunodeficiencies and the stem cell transplant patients or those with cytotoxic chemotherapy. Neuromuscular impairment, a decline of 3.3% after PVC. And of course, the focus for neuromuscular is in the majority primary myopathies and those with actually underlying severe muscle disorders such as myotonic dystrophy, etc. So those get prophylaxed for 2 seasons. So I think that's important to appreciate. Okay, so then I decided to look at your guidelines again and see if there is a similarity. And I was excited to see, oh yeah, wow, this is great, because across Dubai, Abu Dhabi, and the CIMBRO guidelines, there is uniformity. But the question to ask is, we have these guidelines. Are people actually applying them? So I don't know the answer to that question, but perhaps y'all can tell me based on the evidence I've just shown you. So these guidelines are good. You know, there is slight variation perhaps in terms of Down syndrome and whether they should all be prophylaxed or not, but the rest are fairly uniform. So let's look at the Canadian Registry for Synergists in terms of the subpopulations. So you can see here again the exact same slide, but what I want to highlight for you is the numbers which are the highest in the world that have been prophylaxed with palivizumab. So you can see in the brackets for the various conditions, showing that, in fact, if you do prophylax these infants, look at the success rate in the reduction of RSV hospitalization. It was 1.5%. So showing you that in the observational studies, including the study that was recently published from Japan, you have a significant effect. So let's now talk about the 3 strategies that we can and consider to apply. So we first have the RSV pre-F vaccine. Now the NACI recommendations in Canada said, okay, you know, should we use this or not? They were published last year. And they said, no, let's wait for more evidence. But let's look at this data from the randomized controlled trial. So the first thing to recognize, infants born before the RSV vaccine, if you give them RSV pre-F, they're not going to be protected for the 6 months. So the timing of the vaccine is crucial, just starting prior to the onset of the season. So if your season starts in November, the earliest time that you should be given the vaccine is in October. And what happened in Canada last year is because the obstetricians didn't know, they were telling all their patients, oh yeah, you can have the vaccine anytime and you'll be fine. No, because the efficacy wanes very, very quickly. So the efficacy for severe RSV wanes between 3 and 6 months. Look, it drops from 82% to 69%. And then we had the preterm signal from the GSK trial, which actually halted the utilization of the RSV pre-F vaccine in the younger gestational age group. Now, because I have a little extra time, I'll tell you this is a variation across the world. So in Spain, they are prophylaxing all the pregnant women after 24 weeks gestation, because that was done in the randomized controlled clinical trial. So that's fine. But if you look at the numbers, if you scrutinize the data, the numbers between 24 to 32 weeks were very small in the RCT, and they had no way of saying that it was effective and that you wouldn't have any complications because the numbers were so small. But this preterm signal, unfortunately, stopped the use in the younger gestational age categories. The UK are giving it for all women after 29 weeks gestation, and similarly in Australia. We are following the American Academy of Guidelines and giving it between 32 to 36 weeks. But look, to get the antibody production transferred, it has to be done 14 days prior to delivery. If you fail to do that, then you have to consider giving a monoclonal antibody to the baby after the delivery. And now if you compare the vaccine to nirsevimab, you can see the efficacy on RSV hospitalization and medically attended respiratory infection. You can see with the vaccine, 51%, 80% with the nirsevimab. Efficacy on RSV pre-F vaccine drops from 3 months at 68% to 57%. And the nirsevimab is relatively high. So not surprisingly, people are saying, oh, you know, with regard to the vaccine, maybe we shouldn't do it. A lot of education to be done as to how to do it properly. But some countries have been successful. Argentina have just published their data showing clearly that it was very successful in their country. And UK is going to follow very quickly because they went to tender of the RSV pre-F vaccine versus nirsevimab, and because the price and everything of nirsevimab was much higher, in the UK, they're not using nirsevimab at all. They're using RSV pre-F. Okay,